Okay, I think we'll go ahead and get started here. Y'all can continue to come up, get your lunch. Dr. Groom, you probably need to get some lunch. You're working too hard. No? Appreciate y'all inviting me to talk at your Grand Rounds. I'm Dr. Ernest Kiel. I'm one of the pediatric cardiologists. And today I'm going to talk about fetal cardiac arrhythmias. Okay? Intermittently interspersed here, I have a few slides that tell me it's time to change thought process. We took a trip to the south of France a few years ago and we saw all sorts of beautiful stuff. You know, they have these books, 100 of the most beautiful villages in France. I think we went through 25 of them within about a week while we were there. And you just see this, lavender was in full bloom. You would see this just on the side of the road. You just stopped, pulled over, took a picture here. So, if you ever get a chance, you ought to take that trip. Okay, I have no disclosures, but I know nothing about magnetocardiography, so I'm not going to talk about that. And mostly I'm going to discuss ultrasound evaluation of arrhythmias, as well as some of the outcomes and the treatment protocols for a variety of different rhythm variations. So, there are different diagnostic methods that can be utilized, ultrasonography, to evaluate fetal rhythm disturbances. You can utilize M-mode echo, which I like M-mode echo, but I suspect most of the OB guys have no idea what to do with it. Some people are using tissue Doppler, or you can use standard Doppler evaluation, which here's two examples of this, and this is an example of a magnetocardiogram, which will actually give you what looks like a real EKG, and in some instances might be the best way to evaluate the potential rhythm abnormality. M-mode basically is looking at a time reflection of structures. So if I take this 2D image of the four-chamber of the heart and look at my interrogation line and it goes through the left ventricle here, I can actually see the left ventricular wall moving. So every time it contracts, we see a change in the wall. So that's a QRS. And back here, I'm going through the atrial wall, and if you get in the right position, you can actually see atrial wall motion every time there's an atrial systole. So basically, we're looking at P's and QRS's. And in this example, you can see they're not the same, and this is an example of AV dissociation with complete heart block on an M-mode echo. Here are some other examples of M-mode scans that show a variety of ventricular and atrial activity. Here are some Doppler scans showing how you can look at ventricular flow and atrial flow, and you can actually do specific timing that will give you PR intervals and conduction changes. This is my favorite view to evaluate a rhythm disturbance. Basically, your interrogation line goes through the aortic root and the left atrium behind it. You can actually see the aorta here, and you can see the aortic valve. See this little square here? That's the valve opening, so we know that's systole. And you see a nice little dimple in the back here. That's the atrial systole. So we know it's PQRS, PQRS. And I like to utilize this view myself. Doppler can be done in different ways. There's two nice ways of looking at Doppler for evaluation of events and relationships between the atrium and the ventricle. You can get a simultaneous pulse Doppler that picks up both the SVC and the aorta. So I can actually see the systolic flow through the aorta, which is ventricular contraction, and I can also get a smaller minor flow of atrial contraction in the SVC. Or you can get your echo in a view where you're looking at inflow and outflow. So this is kind of a long axis from the apex of the left ventricle. So here's the left atrium, left ventricle, and you see the aorta coming off. So if I put my pulse Doppler sample here, I will see not only the inflow through the mitral valve, but I'll see the outflow going out the aorta. So now I can see this mitral, aortic, and the second mitral peak correlates with the P wave and atrial systole. So here's showing the position you would look at for ascending aortic and SVC flow, and then you can nicely see both the atrial and ventricular activity and look at that relationship. So if you're looking at heart rhythms, I try to make it simple, excuse me, and put it into 3 categories. You're going to see irregular rhythms, or it's going to be too fast or too slow. Those are the things that you're going to see that's going to make you worry. So the irregular rhythms are predominantly premature contractions, premature atrial or ventricular contractions. Atrial flutter and fibrillation can also give you an irregular ventricular rhythm. AV block can be regular or irregular. And then you can have intermittent tachycardia. So you got some tachycardia that stops and starts, and that will make it irregular. Of course, the most common irregular rhythm that you're bound to see are premature atrial contractions. Number of studies have estimated this occurs up to 3% of unselected pregnancies. PACs are most commonly identified later in the 2nd and in the 3rd trimester. When we have premature contractions, they might actually conduct into the ventricle and give you early ventricular contractions as well. But some of the atrial contractions are so early, the ventricle is still refractory, so they are not conducted or blocked, and they don't give you a ventricular contraction. You'll have the atrial contraction, but no ventricular contraction. And I'll show you some examples of this, particularly if it's in a bigeminal pattern. Every other beat is a premature atrial contraction, and that can make it look slow, and that shouldn't be confused with heart block because it's a completely different prognosis and outcome. If you see PACs, it's estimated that somewhere between 1% to 2% of premature atrial contractions might indicate the risk for structural abnormalities. One of the things that's commonly been associated is kind of windsock aneurysms of the foramen tissue in the atrial septum, and that aneurysmal motion can be associated with premature atrial contractions. And if you see fairly frequent PACs, it's estimated at somewhere between 0.5 to 2% of those babies may go on to develop supraventricular tachycardia or abnormal tachycardic rhythms. PACs, far and away, generally are a benign disorder. They need no treatment. Basically, if you see those, it's probably a good idea to just monitor the baby's heart rate once or twice a week for a while to make sure the baby doesn't flip into SVT, although that risk is small. In your literature, it'll say that these generally resolve by the time the baby's born, but I guarantee you, most of the time, if we see fetal PACs, they are still there in the newborn nursery. So I always warn the neonatologist or the pediatrician, guess what, you're probably going to see an irregular rhythm. So here's just some examples, and here's an M mode. Again, I'm showing you're going through the right ventricle, the aortic root, and the left atrium so that you can see nicely the atrial contraction with the P wave. Here's the boxes from the aortic opening. That's the QRS. And here you can see it's a 1 to 1 to 1. And you see it's a nice regular interval. So my sinus rhythm is firing regularly. Here's an example of a premature atrial contraction. It's kind of flipped upside down, so the ventricular motion is down here and the atrial motion's here. So you can see a P and a QRS and a P and a QRS and a P and a QRS, and boop, there's an early ditzel on the atrial wall. That's a P wave. And down here, you really don't see a QRS, and so this is kind of blocked, and it just leaves a pause there. And then I'm back into my regular AV rhythm. Here are some examples by Doppler. We're looking at the ventricular contractions and the ventricular flow with the high peaks and atrial flow here. And so you'll see this, these are 2 sinus beats. The next sinus P wave should be here. So if you measure this P to P interval, the next P should be right here. So when you see this one occur, that's a premature P wave. And it results in a QRS here because I can see flow in the artery. Here's an example of bigeminy. So this And this are sinus beats. If you half the sinus interval, if it was really sinus, the next sinus beat would be here. So this beat is coming early. That's a premature atrial contraction that conducts down to the ventricle. Then here's another one. And usually when they have an early beat, you don't generate the heightened flow velocity because your stroke volume is diminished because you haven't had the diastolic filling, so you won't get as much stroke volume, as much velocity on the premature beat. Here's an example of atrial bigeminy that's not conducted. Now, I've seen a couple of kids that have been referred to me for heart block that really don't have heart block. They have this, and that's good news for the family. Okay, so here we're looking at ventricular activity here on an M mode, and this is the posterior atrial wall. So I see this P and this QRS, and then here's an early premature beat, but there's no QRS. So this is a blocked PAC. P and a QRS, there's another blocked PAC. And you see this happens every other beat. So the effective rate here would be like 70, although the actual atrial rate's normal at 140. So this is no different than just frequent premature atrial contractions. It's generally a benign rhythm. This generally can happen for a period of a number of seconds and then resolves, and you'll see your heart rate goes from 70, 75, and boom, jumps up to 150, and then slows down for 10 seconds and then jumps back up. But I've seen this go on for weeks at a time before it resolves and goes back into a regular conductive rhythm. Now, like I said, the biggest thing is to differentiate this from heart block or complete heart block, which has a completely different prognosis. The EKG after birth would look like this. Here's a newborn and the heart rate's about 75. And on the EKG, we will see every other beat has this premature P wave and there's no QRS afterwards. So this is blocked atrial bigeminy. It does occur. And the clues, I think, for y'all is the heart rate may be intermittently dropping in half, or if the heart rate is half what you expect, you may have to look at your timing to make sure it's not complete heart block. Fetal PVCs are much less common than PACs, but they do occur. In general, they tend to be benign, but can be associated with inflammatory abnormalities and masses. And if there's a premature ventricular contraction, you'll see the premature beat, but you won't see any atrial activity before it. And here we're going along regular, and then there's this double beat. This is actually a ventricular couplet, sinus beat, a ventricular couplet. And over here with the Doppler, we can see the atrial activity down below here, and some ventricular activity here, and here's an early beat that actually conducts at the same time here, but there's no atrial activity before the ventricular contraction. So you'll basically see ventricular motion without atrial motion in front of it. But these are fairly uncommon. I don't know that I may have seen this once over the years, but again, like PACs, it tends to be a benign rhythm change, a benign rhythm variation. But those are the most common things that you're going to see. This is Bonio. We just drove around here, and you just take the little road around here, and all the little French towns look wonderful like that. So if you start looking at significant arrhythmias, here out of sick children in Toronto, they looked at abnormal fetal rhythms over a period of time, and here's what they found, and this is what pretty much everybody finds. The most common things you're going to see are SVT and heart block. As far as significant arrhythmias, there are a few other things. Atrial flutter makes up a form of SVT, and occasionally they'll see sinus bradycardia or tachycardia, which might be representative of other non-primary arrhythmic diseases. So for the tachyarrhythmias, it's going to be SVT, VT, or sinus tach. Okay? And with SVT, most of it's going to be reentry or reciprocal tachycardia. You can have ectopic focused tachycardia, and then there's atrial flutter and fibrillation. I have never seen atrial fibrillation prenatally, but I've seen a number of atrial flutters and a fair number of SVTs. Yeah, that's right. They'll walk in next Tuesday when I'm off. There you go. So you have to know what the normal fetal heart rate by gestation is, and y'all are aware of, all you OB guys know it slows as you advance your gestational age. It's nice to have nomograms because as we start talking about long QT syndrome, briefly, heart rates that are consistently less than the 3rd percentile in bradycardia could be associated with prolonged QT syndrome in the fetus. So SVT is most commonly reentrant or reciprocal. That's where they have a second pathway where they go down one pathway and back up, and they go round and round and re-enter, as opposed to ectopic focus where they have an irritable focus up in the atrium or in the AV node that just sends out fast heartbeats. And these make up, up to 60 to 90% of tachyarrhythmias. With fetal SVT, the rate is generally between about 200 and 300. Most times what we see is 240 to 300 rate for reentry or reciprocal tachycardias. Ectopic focused tachycardia will be a little slower. You may have rates that are about 200 to 220 with ectopic focus or automatic ectopic tachycardia. Most of the time we'll see a 1-to-1 AV ratio, but SVT with AV block can occur. If you can get a good Doppler image, you can measure the ventricular to atrial intervals, and basically you want to separate them out by short VA or long VA intervals, and that may give you a clue as to which of these types of tachycardias you see. So basically a long VA interval is associated more with ectopic focused tachycardia, or what we call PJRT, which stands for persistent junctional reciprocating tachycardia, which is an uncommon form of SVT for us. Patients who have SVT in utero, you will see postpartum up to 30% may have Wolff-Parkinson-White. Majority of them don't. Atrial flutter, on the other hand, will usually have atrial rates that run anywhere from 300 to 500 times a minute. The ventricular rate is usually less, and it may be irregular, or it may be a regular ventricular rhythm that's just a division of the atrial rate. So if I have flutter at 400 and it's 2-to-1, my ventricular rate will be 200. So here is an M mode. Basically, the rate will tell you what's going on, but what you want to do is look to see if you have a 1-to-1 AV relationship. So here we're looking at aorta again. Here's the atrium. So we see atrial contraction, ventricular contraction, atrial ventricular, and it's a 1-to-1. And you can see abrupt cessation of the SVT here, and next thing you know, I got sinus rhythm, 1-to-1. Or you can look at the fetal Doppler and see that there's a 1-to-1 relationship between the ventricular flow and the atrial flow. And here they're actually measuring a V to A interval as opposed to an A to V interval, and this would be a shorter VA interval, which would more likely a reciprocating or reentry tachycardia. Here's another example. I'm going through the left ventricle and right atrium. So I see right atrial motion back here. I can see this mitral valve opening every time there's ventricular relaxation. So it's AV, 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 1-to-1 relationship. So here's an example comparing the reciprocating tachycardia from atrial flutter. So here it's kind of upside down, so the atrial wall's here and the ventricular motion's here, and you can see it's 1-to-1, whereas here is an infant with atrial flutter, and so the atria up here, you see, give these very rapid flutter waves that are regular, but the ventricular response is 1-2-1, 1-2-1, 1-2-1. This is 2-to-1 atrial flutter. One of the things you'll find is that everybody, if you start talking about therapy, everybody has a different favorite drug or favorite approach. And I'm going to show you several examples of just some recommendations and algorithms for therapy. And so one beginning is to, once you recognize fetal tachycardia, look at the AV relationship. If it's 1-to-1 and you think it's probably routine SVT, see if you can tell what the V to A or the A to V intervals are. If it's a long VA interval, it's more likely ectopic focus, either sinus tachycardia or PJRT. Typical reciprocating tachycardia is going to have a short VA interval. And then if you really see real big changes, then you start worrying about ventricular or junctional ectopic rhythms. If your atria are beating less than your ventricles, particularly if you have dissociation, that's ventricular tachycardia. And I'll show you an example of that. And if the atria are faster than the ventricles, then you're talking about atrial tachyarrhythmias like atrial flutter, atrial fibrillation with variable ventricular response. So this is just looking at V to A intervals to try and better define. This you can kind of leave up to us, and we'll try to figure that out, but we treat them pretty much the same. And so when we look here, here's the mitral inflow, here's the aortic outflow. There's 2 beats on most of the AV valve flow patterns. And the second beat is the A wave, which correlates with the atrial systole or the P wave. So this is the P to V ratio here. And so this shows a typical reentry with a short V to A interval. Here is probably more of an atypical, which I take the V and the A interval here, and that's a long VA interval. This is the more difficult to treat SVTs than this is. That's the main thing you want to know about that. So remember, if you're treating something in the fetus, you've got 2 patients, and you have to consider the risk in both patients, both maternal and fetal risks. For SVT, this is a protocol I've utilized a lot in the past called the Utrect protocol. Eric Meinboom, who is from the Netherlands, and Utrect has helped develop this years ago. And so that if you have fetal SVT without high drops, most people utilize digoxin as their primary drug of choice. And so you load them with digoxin. Here it has an oral load. Typically, if you've got SVT that's incessant, I would recommend you just stick them in the hospital and load them IV and watch them for a day or so until you can get enough digoxin on board that you're starting to get close to a therapeutic level. So if they don't convert or slow their ventricular rate, you bump their digoxin up every few days. If they don't convert, then you go to another drug. And in this protocol, they utilize sotalol and add sotalol to digoxin. If there's SVT with high drops, then you can follow one of 2 arms or kind of mix these up. You can start with digoxin. If they don't convert or slow their ventricular rate with digoxin after a period of time and a good digoxin level, then you can add other drugs, and here they would recommend amiodarone. Or you can start with flecainide, and if you don't see conversion or slowing after a period of a few days, you can add digoxin. You can consider direct fetal therapy if these don't work, which we don't have any experience here, and that's kind of plus minus the people who've utilized direct fetal therapy. Direct fetal therapy is basically going transabdominally and giving the baby an intramuscular shot of digoxin. Or some people have given digoxin or amiodarone through the umbilical vein. Some people have given adenosine through the umbilical vein, but they say that's probably a no-no because they've seen bad things happen with that. Atrial flutter responds a little differently, and the drug treatment that most people would utilize with atrial flutter is sotalol. So you start at a typical dose of 80 twice a day. After 3 days, if it's not any better, you go up to 120 or 160 twice a day, up to a maximum of about 320 milligrams a day. And if it doesn't work there, you can add digoxin. Cannot use sotalol and amiodarone together. So you can stop the sotalol if this doesn't work, wait a few days, and then add flecainide or amiodarone if this protocol doesn't work. I've just listed here the drugs, and one of the things that is unique about the fetus is some drugs get into the fetal environment well, so that sotalol and flecainide tend to get into the fetus pretty well. But other drugs don't transmit transplacentally as well, so you have to use very high doses to get the fetal level up to a therapeutic level. The other thing to keep in mind is any baby with high drops they have less absorption and they do not get their levels up as well as babies that are non-hydroptic. So these are the common drugs that are utilized for SVT. I did not list all the potential side effects over here, but I think if you're starting one of these drugs, you probably need to be aware of the potential maternal side effects and watch for that. So like if you're doing amiodarone, you have to check her liver functions. You need to do an eye exam on mom. You need to watch her EKGs. The babies, biggest concern about the babies with amiodarone is it prolongs the QT interval, so you can't use it in long QT, but it also gives them thyroid problems and the concern about potential hypothyroidism in utero and long-term effects, although the studies I've seen have indicated, yeah, they'll have chemical hypothyroidism for a period of time that resolves, and they have not seen any significant long-term side effects with amiodarone used in utero, as far as particularly brain development. Then here are the drugs that are also used, but these drugs are more specifically utilized in ventricular arrhythmias in the fetus. And again, you may have to push these up at a fairly high level to get transplacental effect. This is a recent study of fetal tachycardias. They had looked at a number of studies over the past 10 to 15 years and looked at a variety of things, the percent with high drops, the percent of patients who converted, the number with atrial flutter, the drugs that they used. And basically, all these numbers, I want to point out a couple of things. That if you look at conversion in utero, you see that it's actually gotten better over the last decade. So used to be about half to 60%. You could get converted now with better drug approaches. You can usually convert up to 90%. The other thing I wanted to point out here's hydrops fetalis. And the mortality percent, you see it's pretty high, and if you look, well, it hadn't changed a whole lot in some of these series. So the presence of hydrops and mortality in the fetus with incessant tachycardia is significant. So here's another algorithm for treatment. You look at the babies, how early they are. If they are greater than 35 weeks and you think they're at risk, the easy thing is to deliver them. That's what they all shake their head about, yeah. If they're early, premature, you have to address whether they have a risk for heart failure, whether they're hydroptic. If you can determine the type, that may help you monitor. In this algorithm, they really like digoxin and sotalol as combinations. So you'll see here, digoxin and sotalol are their initial drugs. If that doesn't work, then they'll stop the sotalol and change to flecainide. And then eventually they'll get down here to amiodarone. Well, that depends on the rate of the tachycardia and the underlying presence of congenital structural abnormalities. And those babies with structural congenital heart disease have a significantly increased risk of arrhythmias for having heart failure and myocardial dysfunction. Other things that might give you a risk if you have tachycardia in light of something like parvovirus with cardiomyopathy and stuff like that. Now, last year, the Heart Association came out with a scientific statement, and I brought a dozen or so copies of this for the OB residents if they would like, because it's a nice summary of fetal arrhythmias, about what you do and what their recommendations are. And so when you look at fetal SVT, their recommendations are if you have SVT or Flutter with no hydrops or ventricular dysfunction, your first or second line drugs are dig, flecainide, and sotalol. And the third line drug is amiodarone. But you stay away from verapamil and procainamide. If you have SVT with a heart rate greater than 200, without hydrops or ventricular dysfunction, it's the same drugs, pretty much the same, whether you're hydroptic or not, or non-hydroptic. So they like these three. They recommend these are the three drugs you consider starting therapy with. If you have SVT at a rate of less than 200 or intermittent SVT that occurs less than half the time, you don't need to treat them, just observe them. And unless they have changes or they're concerning, you probably get by without, excuse me, without any treatment of those. If you have atrial flutter, then their top drug they like is sotalol. Consider digoxin, amiodarone, and you don't use procainamide. And of course, in any of these, you can consider delivery in any of these if the baby is fairly mature, and particularly if you have mature lung parameters, and so that you can do direct therapy on the baby. The last baby we had came in with incessant SVT pretty much. We started with dig, went to flecainide, we're getting ready to go to amiodarone, but she seemed like she was hydroptic, seemed like it was worsening, so she was delivered and she was treated postpartum, eventually got loaded with amiodarone, and that took care of everything. I saw her 2 weeks ago in the clinic, and the baby's happy, smiling, and looks great. Mom's happy. Gagey had an article that looked at comparison of digoxin, flecainide, and sotalol a couple years ago, and basically these are the percent of fetuses that no longer have, that are the higher numbers are those that continue to have tachyarrhythmias. So you see if they treat atrial flutter and SVT, SVT is less likely to have ongoing tachycardia with drug treatment than atrial flutter. If you treat incessant SVT, they're less likely to respond, whereas if it's intermittent, they respond usually quite well. And if you look at the three drugs and look at this as reciprocating tachycardia and flutter, you'll see that actually sotalol is the least effective compared to digoxin and flecainide in regular SVT, but sotalol is better with flutter. So their conclusion was that dig and flecainide in combination were superior to sotalol, but they, in treating SVT, but they thought sotalol was the drug treatment of choice for atrial flutter. Okay. So let's switch now to the slow heart rates, the fetal bradycardia. So the possibilities are sinus bradycardia, AV blocked atrial ectopy, atrial bigeminy, ectopic atrial or junctional rhythms, and then bradycardia that's been associated with prolonged QT syndrome. And so Dr. Cuneo has looked at an algorithm, or most algorithms are kind of like this. You look at the heart bradycardia, and you see if it's a regular atrial rate and a 1-to-1 conduction, or if it's regular and there's a greater than 1-to-1 conduction, which is heart block, or if it's irregular or a blocked atrial bigeminy. So this would be the benign form that you would just be very conservative and just do follow-up with. If you see a regular rate with 1-to-1 conduction, check the cardiac structure. If there's structural congenital heart disease, you want to define the anatomy, counsel the family depending on the anatomy, and then do frequent follow-up. So here's an example of, I have a fetus who has a heart rate of 110 that's regular, and I find this fetus has complex congenital heart disease, and he turns out to have left atrial isomerism or polysplenia syndrome, and he has an ectopic atrial rhythm or a junctional escape rhythm. And so there, your outcome is going to depend mostly on the underlying anatomy of the structural heart disease. If the structural heart disease is normal, then see if the mom's on any meds that will slow the rate, check her thyroid, look at SSA and SSB screen, and if her thyroid's abnormal, treat her. If she's on meds that are causing that, do that. If she's got SSA or SSB, consider treating her for that. And if these are all negative, then you ought to consider the possibility the bradycardia may be associated with prolonged QT syndrome. If they have AV block, which is basically atrial rate greater than ventricular, again, you look for structural heart disease or normal structure. If they have structural heart disease, here's the big cutoff. Heart rate of 55, less than 55, you ought to consider that they're going to get in trouble. Greater than 55, they usually will do okay. If they have a normal structural heart, you have to look for the potential for collagen vascular disease.
So if we saw a heart rate of 55, that baby would be in the NICU probably. I mean, we want to take the patient back and what would it look like on the fetal heart rate tracing so that we know that's like the rhythm of the baby and the baby's not having a big
AV
VC?
block, your heart rate's basically going to be set and not change.
Okay.
It can be 55, it can be
Just a flat
straight
line
across,
at
flat line.
55.
And so blocked atrial,
So that would scare us.
yeah, but, you know, and it's a recurring theme. We see this all the time. Oh, 30-week gestation, went in, the OB count, said bradycardia, heart rate 60, boom, stat C-section,
That's what I was thinking.
baby has heart block. And that baby then, we've got one kid now who's 15, 16, delivered at 30 weeks from East Texas, down at Willis, and sent to Willis Knighton. The kid had ventricular hemorrhage, interventricular bleed. He has CP, mental retardation now, and he's a nice kid, but he shouldn't have been delivered. So if it's consistent rate, it's not variable to cells,
So just flat?
it's flat line,
that
then you
sounds-
really have to evaluate to see if it's heart block.
That's just a scary thing.
It's
for
a
an
scary
obstetrician
thing.
to
That's
see
even
on a-
scarier because the lawyers know all about this heart block and know they shouldn't be delivered. That's just as scary. Yeah, and it's scarier when you're out in practice. When you're in a center like here, you can always call somebody who has a little more experience and expertise and do that. But the other thing is those babies who have AV block that have a rate that's pretty good, all their other parameters of well-being are going to be fine. Nothing else that's going to suggest fetal compromise with those babies. I don't know, is there a simple answer for that?
Not really.
Straight across, think of heart block.
But their PPP should be normal.
Yeah,
They should be moving around and.
It's not
you know,
floating
they're not like,
you know, like you're about to die.
Yeah, but you have to look at your other parameters and keep it in mind.
Yeah, but we don't routinely, if we get called to strips down, we don't go and
no,
get,
they're not, it's been down the whole time.
Had been up, then goes down. And it's flat.
okay, so
So,
that's what I'm saying. If the
so
nurse
they
put the
can't
patient on
ignore.
the monitor, as soon as they put it on the monitor, it's 55 and it stayed at 55, my first inclination wouldn't be go get the ultrasound. That's,
Yeah, that's your first
because
inclination.
that's what we're
You need
trying to do
ultrasound.
is,
And not go to the stat C-section, you know.
well, now I know not to.
You know, and I can't tell you that, that's a difficult problem for y'all. It's easy for me to sit here and say, oh, it's heart block, you know. But y'all are caught in that on the front end lines. But realize when it's slow, if it's been variable, that's different than just 55 all the time. Okay, but again, the chance the baby's going to get in trouble in utero is rate dependent. So rates 55 to 60 or higher, the babies usually will not develop myocardial dysfunction, high drops, any problems. Less than 50 to 55 though, they will tend to start developing myocardial dysfunction and they can get heart failure. So when the rates are less than 55, they would consider giving beta mimetics, salmeterol or some sort of beta agonist therapy, or steroids, which I'll show you some stuff. And if they have a normal structure and they don't have SSA or SSB positive, keep in mind they may be one of those babies, particularly if the rate's significantly slow, that shows up with long QT.
Most of the ones I've seen, if they have like rates in the 80s is more, I mean, with the few that we've had, they haven't been like, I've never seen any below 50. So,
I have. I've seen 40 to 45. Yeah, yeah, okay. So if we look at fetal presentation of congenital heart block, you know, before echo, it was mostly suspected when they had a regular bradycardia, and the rate was consistent with some sort of escape rhythm, which junctional escape rhythms generally run anywhere from 40 to 60s. And so you're going to be in that range, but babies, mostly they're 50 to 60 range. Advent echo allowed people to look at the activity of the heart and be able to actually determine if it was heart block. And so you use M-mode or Doppler to confirm the presence. You can also look at the function of the heart and look at the structure of the heart. And so here are a couple of Doppler images here that show that you can actually measure the PR interval in utero. So when y'all send me some mother who's maternal lupus, I'll measure the PR interval. So remember the second beat on the M, that's the is the mitral or the AV flow, is a P wave. So the PR interval would go from here to here. Same thing here. Here's the PR interval from here to here. Normal PR interval in the fetus is indicated 80 to 140 milliseconds. More than 140 would be considered prolonged. So you might see first-degree heart block by measuring PR intervals, but we're not going to do that unless we have a mother who's at risk. Here again, showing some M-mode measurements here. This shows one-to-one conduction. Now here's a printout that shows atrial activity faster than ventricular, but this is not Flutter because the rate's not rapid. The rate is normal, and we'll see that then the ventricular rate is subnormal. And then you can look for whether there's a pattern here, so that if it's like 3 P's to a QRS and the P to R interval is constant, it may be a fixed rate block. But if you don't see a constant P to ventricular rate, which there's not here, it's AV dissociation and complete heart block. You can see second-degree heart block, and you can determine that by, again, looking at intermittent changes that occur where the ventricular rate is irregular with second-degree heart block. Most of the time it's going to be irregular, but it can also be regular with fixed ratio block, 2-to-1 second-degree heart block. And there you would look at mitral valve motion, and you can see that these are fairly regular intervals. This one conducts, this one doesn't. This one conducts, this one doesn't. And so this would be every other beat is blocked at a fixed ratio, and that'll give you a ventricular rate that's regular, but most second-degree heart block is going to be very irregular. So you'll see up, 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 up. But fixed ratio block can be a problem. And again, if you think there's heart block, you have to rule out the fact that they have fixed bigeminal premature contractions. And the way you look at that is if I have heart block, then my atrial activity is regular, okay? So I can follow this along. It's the same distance between each P wave, sinus. If I've got blocked atrial bigeminy, you see these two are closer together, these are farther apart. These are closer together, these are farther apart. And so you see that every other beat is early compared to the preceding beat. And then this one doesn't conduct, so your rate's basically half of what your atrial rate is. Structural heart disease does occur with heart block in the fetus and in the newborn. Anomalies have been found. Average about half of fetuses with heart block can have some sort of structural congenital anomaly. Previously, it was estimated about 30%. The most common thing that's seen is left atrial isomerism or polysplenia, and they often have very complex heart abnormalities. You can also see heart block in utero with what's called congenitally corrected transposition or ventricular inversion disorders. We don't expect you all to do this, except notice the heart looks funny, and we'd have to make these diagnoses. Occasionally you can see heart block with AV canals and other more common disorders. Unfortunately, if you have a structural heart defect with heart block, the mortality can be fairly high, and 3 studies in the 80s and 90s saw a mortality of 70 to 80% and over 170 fetuses. If the heart is structurally normal, then you have to be concerned about the association of maternal collagen vascular disease, and that can be seen anywhere from 12 to 60% of the time. And some rheumatologic clinics that do evaluation see a larger percentage. When I was in London, Lindsay Allen said there was a 70% chance of a positive SSA or SSB if the heart was structurally normal with heart block. The fetal mortality in the past has been much less than associated with congenital heart structural abnormalities. And the risk for need for a pacemaker or fetal loss, again, is associated with rate. Rates over 60, low risk. Rates less than 50, higher risk. 50 to 60, intermediate risk for problems. High drops with fetal heart block is an extremely high risk. And most of the time, block develops between 18 and 30 weeks. And if you have one mother with heart block, the chance that they may have another because they are SSA or SSB positive is not 100%. It's about 20% chance that it will recur in the next pregnancy. So if you see fetal heart block, this is an algorithm that looks at diagnosis of fetal heart block, okay? So if they see heart block, they're going to treat with steroids if there's a good rate or if there's a bad rate. But if the rate's less than 55, they're also going to add a sympathomimetic to maternal therapy. And those have been shown to increase or improve ventricular output and stroke volume by just increasing the rate a little bit. And you can actually resolve high drops or reverse high drops with beta mimetics in some case reports in the past. Then you follow them weekly, and then if they're uneventful and they get near term, you deliver them. If they have progressive high drops, you can consider delivering them and pacing the baby. The neonatologist will see this. They see low output. You can treat with isoprel or epinephrine, but pacing is probably going to be necessary eventually. If there's maternal lupus, steroids may be helpful. If they have poor function with fibroelastosis, IVIG has been reported as improving function over time. The impact of transplacental steroids and fetal heart block has improved survival. Here, just if you look at decades of evaluation, here's the 1990s up into the later 90s, you see survival of heart block is better. If you use steroids, this is no treatment and no steroids, and they follow a treatment protocol with steroids or a protocol, you see survival is better. Just to point out here, there's a couple of summaries of fetal heart block from a variety of different studies. You can see the numbers here, but I want to point this out. Here is structural defects with heart block. This is survival. See, it's anywhere from 12 to 50-some%, but survival is probably about 20 to 30% in this group. That means 70% mortality. If they have isoimmune heart block, survival is much better out of these studies. So association of major structural heart disease with heart block is a bad thing. And then I'm going to finish here just briefly talking about a couple things I've never seen. Fetal ventricular tachycardia, which is fairly rare, generally diagnosed if you see a ventricular rate that's faster than the fetal rate. There was a review a couple years ago of 24 cases of what they thought was ventricular tachycardia, and actually 6 of those cases after birth were found to have junctional tachycardia and not ventricular. But of the patients, of the 18 patients that had ventricular tachycardia, 12 of them had confirmed long QT, and that's where all the deaths came from. The heart rate with ventricular tachycardia is variable. It may tend to be a little, on the average, low to mid 200s instead of the higher 200s like SVT will be. Most common drug that has been used with ventricular tachycardia is propranolol, which has been partially successful. If you have ventricular tachycardia and you're concerned about long QT, these drugs which prolong the QT interval, including amiodarone, are contraindicated. And then if you have often those patients who ended up with VTAC, they would go back and find they had a positive family history for long QT. So here's the M mode, and you see the ventricular rate is much faster than the atrial rate. This is basically AV dissociation, no relationship between the A's and the V's, and a rapid ventricular rate. This is one protocol that's come out of Herman Hospital in Houston. If you suspect ventricular tachycardia, refer to a fetal center. You do a comprehensive evaluation. You look at you can confirm it's ventricular tachycardia. They would put in their antenatal unit. They would get a maternal EKG, check maternal electrolytes, magnesium. If there's fetal high drops, they would look at a variety of other labs. And then they would start maternal IV MAG and oral propranolol. And they would load with MAG and then continue on a MAG drip. Magnesium sulfate has been used for ventricular arrhythmias, ventricular tachycardia, and fibrillation, predominantly with long QT, and that's thought to be probably your initial treatment of choice if they're in big time trouble. It can be effective, but you can only use it for like 48 hours, then you have to stop. And then if they go back into VTAC, you can do another dose later on. But the idea is to start with magnesium and try to use propranolol for an oral drug as a suppressive drug. And if these two don't work, there's been reports of using lidocaine. The oral analog for lidocaine is mexiletine. So if this didn't work, you'd put them on oral mexiletine. And then you really have to watch for long QT if you see ventricular tachycardia. Prolonged QT in the fetus is a fairly rare disorder too. It may present with sinus bradycardia that's consistently less than the 3rd percentile for the gestational age for reasons that you can't figure out. It's also been associated in presenting with 2nd-degree heart block. Or if you see ventricular tachycardia, you think of long QT. And if you're concerned about prolonged QT, you got to check mom's calcium, magnesium, and vitamin D status because hypocalcemia, hypomagnesemia, and vitamin D problems will lead to secondary long QT prolongation. And if you're going to end up treating mom with mag, you need to know what her level is too. Look for the mother to be on drugs that are associated with prolongation of the QT interval because those can go transplacental and affect the baby. And you want to watch the mother's EKG and check her, make sure she doesn't have long QT. You only treat if you have ventricular arrhythmias that are thought to be compromising the baby. And if you really think they have it, probably the best way to diagnose that is to send mom to a center where they do fetal magnetocardiography, which is like doing an MRI. You have to have a shielded big magnetic room that's a pretty expensive test. Only a few places have it. Although they're talking about setting up these mobile magnetocardiography trucks that you can go around with. Okay, so this is my wife and daughter sitting in the field in the south of France. You can see they're smiling, they're happy. So that's pretty much what I have. I would tell you if you see this, don't call me. I don't care what the heart rate is. Call Dr. Bruyette. She would love to see this, and she'll deliver this little alien for Dr. Koo if that occurs. So hopefully that helps you understand a little bit more about some of the complexity about fetal arrhythmias, some of the scary things about fetal arrhythmias that experience helps more than anything. I have a little experience, kind of a medium experience. I don't see lots, but I have seen enough that I can help, but also seen enough to know when we can't do a whole lot.
You talked about some of the tachyarrhythmias and irregular arrhythmias developing 2nd and 3rd trimester. What about the bradycardia? Is that from the get-go, or is that?
For the bradycardia? Well, it all depends on what the etiology is. So if it's bradycardia from heart block, that tends to develop in that 18 to 27 to 28 gestational range, rather than later on like the ectopy. And so these ectopy PACs basically are the ones that develop later. Bradycardias, if their heart block can develop earlier, SVT can occur at any gestational age. That can occur at 20 weeks or 24 weeks or 32 weeks. I've seen them at all different ages and things. Other questions that you have? Thank you very much. You've been a nice audience.